Good morning. Thank you. My name again, Michael Boylan from WJCT here. Welcome home. Welcome back. I'm glad to have you here. This is a large crowd, so thank you for being here. How many of you, this is your first time? I'm just curious. Well, thank you for coming. And most of you have seen, I'm certain, at your seats, the Save the Date card for Speaking Women's Health coming up. Our committee is working very diligently and putting together an excellent program for this year. And we are limited to the number of available seats, so if you want to sign up, I would encourage you to go online and do so as quickly as you possibly can. Again, we always appreciate the opportunity to share with you some good news, and we do have a little bit of good news, but I might need a little help on your part. As you know, last year, WJCT lost a significant amount of funding from the state of Florida. The legislature spent a lot of time this past year taking a look at just exactly the impact that public television has in education, particularly for our preschool and our school-age children. And we're actually wise enough to make the decision, this isn't being recorded so I can say that, to recognize the importance that we play. And we've seen a little bit of money going back into the budget to support public broadcasting here in Florida. So let's give our legislators a hand. As you may recall, however, it was the governor last year who vetoed that money, although it was in there last year. So if you go to our website, we are still a little bit on pins and needles, making certain that he does honor his verbal commitment to support the decision of the legislature this year. But it wouldn't hurt to nudge him, to let him know how much you appreciate the support of the WJCT here in the First Coast, and that you think it's a great investment of your tax dollars. The reality is it's really difficult to make up that kind of money, over $500,000 that we lost last year through individual donor support. And one thing they don't take into account is the time, energy, and resources we have to expend in order to make up those dollars. So it really is a wise investment. It allows us to provide more time and more opportunities to focus on the service and the programs we provide you, like this one today. So if you take a moment to go online, there's a place to click on wjct.org and to let the governor know you appreciate his support and his wise decision of supporting the legislature's budget for WJCT. It is not, certainly doesn't make up all the money we've lost in the past. It's a portion of it, but it's a start, and we do thank you for that support. I do want to remind you just a couple of housekeeping items. I assume most of you have found the restrooms, but they're down the hall, first hallway to your left as you go down through the gallery. Secondly, make certain that you turn off or put your cell phones on vibrate so we're not interrupted during the course of the conversation in that embarrassing moment when you have to throw your hands in the air and reach for your purse or pocket to pull out that cell phone to turn it off. And I thank you for that. I understand there's a young lady who's looking to collect the water bottles. Can you raise your hand? We're going to have a couple of bags back there for her, so don't toss your water bottles into the trash can, but make sure she gets them as you exit today. So they're using them for an art project downtown? I'm sorry? Oh, excellent. What a great idea. Thank you so much for doing that. We do appreciate that. Again, Baptist Health is a great supporter of this partner in this process, and we want to recognize Baptist Health again for their ongoing support of the Speaking Women's Health event. And today we have some interesting guests, however, as you can tell, of great interest to all of you. That's why you're here. But to introduce our speaker today, we have Stan McQuiston from Barracks Medical. Stan, come on up.
Thanks again, everyone, for being here today. WJCT and Baptist Health Center for Endoscopy are pleased to welcome today's presenter, gastroenterologist Dr. Vikram Gopal. Dr. Gopal is a graduate of Stanton College Preparatory School here in Jacksonville. He received his medical degree from Emory University School of Medicine in Atlanta, where he received the Overall Excellent Award for Service, Leadership, and Academics. He was also inducted into the Emory University Hall of Fame, the highest honor bestowed upon an Emory graduate. Dr. Gopal completed his internship and residency in internal medicine at University of Florida in Gainesville, go Gators, where he twice received the Outstanding Resident Teaching Award. Following his internship and residency, Dr. Gopal completed a fellowship in gastroenterology at Wake Forest University in Winston-Salem, North Carolina, during which he served as chief fellow. Dr. Gopal is board certified in both gastroenterology and internal medicine. Please join me in welcoming Dr. Vikram Gopal.
Thank you. Can everyone hear me? Can you hear me? Good. I'd like to thank Stan from Barks Medical, WJXT, and Baptist Health for having me here today to talk about a very interesting topic. So how many of you in the audience today have ever had heartburn? Raise your hand. Okay. How many of you are on medication for heartburn? Raise your hand. Okay, very good. How many of you know someone who has had esophageal cancer? Raise your hand. Okay, so good. This is very relevant topics for this day and age. And the biggest thing that I wanted to take home from this is prevention. And prevention is the best thing we can do. And so my topic was heartburn can lead to heartache. Not truly heartache as a heart attack or arrhythmia or ventricular tachycardia. Actually, heartache in the loss of a loved one, the stress of dealing with a medical condition that has a very high mortality. And that's the heartache that we're dealing with. One patient asked me, does it really cause a heart attack? And I said, no, it's the heartache from esophageal cancer. And not everyone with heartburn gets esophageal cancer, but it is something to think about, and that's what we're going to discuss today. So basically, we're going to talk about Barrett's esophagus. What is Barrett's esophagus? And how is it created in the body? And what does it do long term? The unfortunate esophageal adenocarcinoma. And then treatment options we have at Baptist Medical Center here at the Baptist downtown campus. And then we'll open it up for some questions. So here's the esophagus. You can see that. It's the feeding tube that leads from the mouth to the stomach. It is a transit tube. It is not a storage tube like the stomach. And it provides motility of food and water and nutrition to our bodies. So Barrett's esophagus was identified by Dr. Norman Barrett. And Dr. Barrett was born in 1908 in Australia. He was a thoracic surgeon. He practiced in England. And in 1950, when he was doing surgeries of the chest, thorax, lung, esophagus, he was noticing that the tissue looked a little bit different. And in the microscope, it looked different than the rest of the esophagus. And so it was termed Barrett's esophagus for Dr. Norman Barrett. So that was in 1950. It wasn't until 1975 that it was confirmed that Barrett's esophagus can lead to adenocarcinoma or esophageal cancer. So it took some time to say these cells, these changes can lead to esophageal cancer. So basically here you see the stomach. The stomach produces acid to digest and break down food, just like the lunch we're having. And that acid and acid reflux can reflux back into the esophagus, causing significant discomfort, nausea, vomiting, and even chest pain for some. Over years, that acid reflux can cause damage to the esophagus. So just a little cartoon here. GERD, more than just heartburn. And you see this heart and burning. Really, it has nothing to do with the heart, but patients can confuse it with heart symptoms. So be aware of that. So it's kind of a cute term of saying heartburn, when really it's esophageal burn. But we call it GERD, or gastroesophageal reflux disease, reflux, heartburn. So just be aware of that. It has nothing really to do with the heart. Okay, so basically, GERD is the third most prevalent disease in the United States. And probably half of you raised your hand when said you ever had heartburn. And then half of these patients usually have symptoms, weekly, monthly, and regularly do take medications for it. And you should talk to your doctor about acid reflux and heartburn symptoms. But why do we get acid reflux, and why do Americans get it more than other industrialized nations? And a lot of it has to do with overeating, supersizing, obesity, and things that are not good for overall health. It's usually, unhealthy lifestyles that cause acid reflux. And we're always wanting to eat a little bit bigger, get a larger meal, maybe get a big 32-ounce drink. And all of these things are not adequate for the stomach to hold. We're supposed to be foragers. We eat small meals, and we should. But unfortunately, we try to cram in a lot amount of food in a short amount of period due to our busy lifestyles and schedules. And that's one of the things that leads to acid reflux. And you can see the CDC has said that half of the U.S. population is overweight or obese, which is a problem. And so, food for thought, talking about the supersized nation, and just like I talked about earlier, and that's probably one of the reasons we all do get acid reflux. We overindulge, and our quantity and portion size are a little bit too big for us. So, what is Barrett's esophagus? Barrett's esophagus is the change in the cellular lining of the esophagus, and it is where the cells of the esophagus change to be more like the stomach. The stomach likes the acid, but the esophagus does not. And so over time, when the esophagus is exposed to acid, it says, wow, I hate this. It burns me. It hurts me. It causes damage. Well, let me start to change. And let me start to change to a cell that likes the stomach. And in that change, unfortunately, is the progression to esophageal cancer. So, just to clarify, there's 3.3 million adults in the United States with Barrett's esophagus. And Barrett's esophagus increases your chance of developing esophageal cancer. Not everyone with Barrett's esophagus gets esophageal cancer, so I want you to be clear about that. So if your doctor tells you have Barrett's esophagus, there's options to treat it, and we'll discuss that a little bit more. But you shouldn't be overly concerned that I'm going to get esophageal cancer today or tomorrow. It's something that discuss over long term. Okay? So we talked about basically symptoms of acid reflux, heartburn, regurgitation, chest pain. And usually it's the damage of the lining of the esophagus from acid that causes this change. And there's also a genetic predisposition. Smoking sometimes can accelerate it. So as we know, smoking is not good for us. So if you are smoking, please work on stopping and talk to your doctor about stopping smoking because it is a big problem with accelerating cellular damage, and that cellular damage then leads, unfortunately, to cancer. So basically, how can you identify Barrett's esophagus is by doing an endoscopy, by a gastroenterologist passing a scope into your mouth, esophagus, stomach, and small intestine, looking at the lining and looking at the change. And I'm going to show you some pictures of Barrett's esophagus in a minute so you can understand that. So 13% of people who have chronic acid reflux disease, 13% have Barrett's esophagus. How do you know? You should have an endoscopy. So what are the risk factors? Increasing age. And what is increasing age as our population is increasing and we're living longer? We say patients over the age of 50 should be screened for Barrett's esophagus if they have a long-standing history of acid reflux or heartburn. Men are most likely to get Barrett's esophagus, but what I want you to take home from this, it can happen in women, and I see many women with Barrett's esophagus, and there are women who do get esophageal cancer, but it's more predominantly in men, more predominantly in Caucasians, but all races can get Barrett's esophagus. And once you take different nationalities and races and bring them to the United States, bring them to the supersized nation that we are, things can happen to the esophagus also. So just be aware of that. Smoking, as I talked about, is another risk factor, and long-standing GERD symptoms. So just because you have heartburn today after this meal does not mean you're going to get esophageal cancer, okay? Long-term, that's the key. Okay, so here we have Barrett's esophagus. And I want to point out to you, this light white pink is the normal lining of the esophagus. You see it right there. The dark salmon-colored, darker red pink is Barrett's esophagus. So what that means is over time, the cells have changed in the light pink to become this dark area. And you see that here. And there's these little projections, which we call tongues as gastroenterologists. It's almost like someone sticking their tongue at you, and you have a tongue over here, a tongue over there, a tongue over there. But then if you go beyond that, we call that circumferential Barrett's. It's around 360 degrees, where it should be that light, nice white color. You see this pink salmon-colored lining. And then here you see the flames. You see those red irritations in that top picture of the endoscopy of the esophagus? That's esophagitis. And that's the first step in damage and chronic acid reflux. It causes irritation. And it does look like a little light flame. And those are irritations where there's injury to the cells and lining. And years of that injury and to the lining can then lead to Barrett's esophagus, which is that second picture there. And in this third picture, that's what adenocarcinoma or esophageal cancer looks like. It's very large, it's rough, it has no structure, and unfortunately can spread to the entire body. Okay, so there's another picture here. One nomenclature here. This picture here is a normal lining of the esophagus. See that perfect round circle? That's the way it should look. There's a little mushrooming there, and that mushrooming is basically, right, good, the pointer's actually working. This is a small hiatal hernia. A hiatal hernia, which most of us probably do have some size of a hiatal hernia, is a non-surgical issue unless it's a significant hernia where your stomach is in your chest. So don't be alarmed if your doctor tells you you have a hiatal hernia. Now, not an inguinal hernia or an umbilical hernia. This is a hiatal hernia. So it is not a surgical issue like other hernias. But in this picture, you can see a small hiatal hernia. And then you see after chronic inflammation, you then see damage to the lining here. You can see that here. These flames of irritation and erosions of the lining from acid reflux. And then eventually, you have these tongues of Barrett's esophagus. The ironic thing is, patients who have had acid reflux for many years, all of a sudden don't have acid reflux anymore. They don't feel it as much, and they stop taking their medication. And it's usually because the lining has already changed to accommodate that acid like it was trying to do. And they say, oh yeah, I had acid reflux for 20 years, in my 40s and 50s, I didn't need the medication anymore, doc. And that's usually because the lining has already changed. And then unfortunately, once again, the esophageal cancer at the bottom. Here's a picture here in an operating room of a thoracic surgeon removing, sorry, let me go back one. Sorry about that. Go back to that slide. Okay, so going back to this slide here. In this slide, the esophageal cancer is right here. This is all esophageal. This is the esophagus. This is the stomach right here. So they're dissecting out the stomach, and they're removing this section. And most likely in the surgery, they're pulling the stomach up into the chest to give them a way to eat. But this is what we're trying to prevent. So this is the transition from normal cells to Barrett's esophagus. So here you have, what we have is the vanilla Barrett's, plain Barrett's esophagus. And over time, that Barrett's esophagus can then have varying degrees of dysplasia. Then you start seeing low-grade dysplasia. These cells are perfectly square, and they have a little nuclei in them. And then in low-grade dysplasia, you start seeing multiple nuclei, 2 different nuclei here, and they're not perfectly, on one side of the cell. In high-grade dysplasia, you have multiple nuclei, and they're not taking any structure, and they're accelerating their growth. In invasive cancer, then you see these cells take off, and they go to all layers of the esophagus and can spread throughout the body. But this is the progression of Barrett's esophagus into esophageal cancer. Very interesting slide here. These are the rates of cancers in the United States. And this is with the journal from the Cancer Institute. And I want to give you some idea here. So if you look here at colon cancer is this pink line right here. The rate. This is not the numbers of cancer. This is the rate of cancer. Colon cancer because of colonoscopies. Now, how many of you have had a colonoscopy in the room? See? That's very good. And because of this screening, the rate of colon cancer has decreased from 1975 to 2000. So you can see that trend. That's screening. If you look at breast cancer is staying about its level. It's not increasing, and it's staying about the same. And we're still diagnosing, but the rate is about the same. Prostate cancer was a big problem. It was in the 90s, and then now it started to come down with PSA screenings from urologists, primary care doctors being more aggressive about evaluating prostate cancer. Then here you see lung cancer, unfortunately, rising because of cigarette smoke and secondhand smoke. And then you see esophageal cancer. The rate of it is increasing. And it is because of the supersized nation we talked about the CDC saying 50% of Americans are overweight and obese, large meals. So that's the trend that we're seeing, and it's definitely pointed out here because I guess here the rates were a lot smaller because of our lifestyle. And now you can see, because of our lifestyle, the rates have started to increase. And that's a big problem. So just to give you the estimates here in the United States, 1.6% of the general population, which is about, this is adults now, not children, 3.3 million patients in this one study have Barrett's esophagus. And in another study, they evaluated that 4% to 6% have esophageal cancer in the adult population. Another study thought people over 40, 6.8% have Barrett's esophagus. And well, the ironic thing is 25% of people with Barrett's esophagus do not have any GERD symptoms at all. So I think those are the patients that we should screen because of family history, smoking, and that's usually after age 50. So there are patients who do have Barrett's and have not had any GERD, or they don't complain, or they thought that's normal to have some acid reflux or some indigestion or a little bit of burping after meal. So they might not know what really acid reflux is. They may think it's normal. I treated a patient once and put him on acid medicine for what I saw was esophagitis. Doc, I don't feel anything. I feel fine. I don't have any heartburn or indigestion. It wasn't until I treated his acid reflux did he really know what was normal and what it should feel like after a meal. He thought it was basically normal to have the symptoms he was experiencing before a meal. So each person's different, and you have to ask each patient, what their symptoms are. Okay. So fortunately, there are treatment options, and that's what we're going to talk about for Barrett's esophagus. And with thanks to Baptist Health for the technology and support to Barracks Medical and WJXT, we're going to talk about how we can try to prevent esophageal cancer and hopefully try to decrease that rate. So if you look here in this picture, this is Barrett's esophagus again. You guys can see this, the change here. This is normal. This is an island of normal mucosa, but you can see how the change of the lining because of chronic acid reflux. This is the colon, and this is a colon polyp. And if I were to see this while doing a colonoscopy, I would easily remove it because this polyp has the risk of developing colon cancer. And we've seen that rate decrease because of colonoscopies. And I thank you for getting colonoscopies. It's important to know what's lurking in your colon, if there is anything. So if this was a polyp in your colon, I would remove it. Now this is Barrett's in your esophagus. The rate of these two turning into cancer. So if you had plain vanilla Barrett's esophagus, your risk of developing esophageal cancer is 0.5% per patient per year. So if I had Barrett's esophagus, this year I have a 0.5% chance of getting esophageal cancer. If I was a betting person, I'd probably say that's probably unlikely that I'm going to get esophageal cancer. That's 1 in 200 people. But over time, cumulatively, my risk can increase to 5 to 10% over my lifetime because of my risk. But so, as I said before, the take-home is just because you have Barrett's esophagus does not mean you're going to get esophageal cancer. Just realize the risk is a lot higher than the average population. If you have high-grade dysplasia, that's when we saw all those nuclei and all those cells, it increases to 1%. So that's 1 in 100. So that's even more accelerated. And over time, over 5 to 10 years, the chances are probably about 25% chance if you have high-grade dysplasia of your Barrett's of developing esophageal cancer. And in the United States, believe it or not, because just like you're one of the 7.5 million people who have had colonoscopies every year. So it's a very good thing because it prevents colon cancer. Okay, so what are your treatment options? And your doctor will be able to discuss that with you. One would be to just surveillance, to watch and wait. Look again in a year, look again in 3 years, and biopsy and see if there's any change to the Barrett's esophagus. And that was what the norm was. We had no treatment options. And it's still, for certain individuals, surveillance is not a bad option. But then there was the invent of photodynamic therapy, PDT. PDT is where they actually give you an IV medication that's very sensitive to light. And when you get this medication, you cannot be exposed to sunlight because it causes burning in the cells. You then do an endoscopy, expose the tissue to light, and that tissue then burns or destroys itself because of the chemical that was injected in your IV. So that was one of the initial treatments, and it was successful at that point. Now there's some better therapies. The other one that I also perform is called endoscopic mucosal resection. That's actually where you raise the tissue and you try to remove it, but the esophagus is very thin. There's a risk of perforation, there's a risk of a hole forming, but you then can at least try to eliminate a major surgery where you have to crack open someone's chest or go into the side of their lung to try to treat this area. but you can try with your scope, and the scope is only the thickness of the top of a pen, so it's actually smaller than my finger. So with that we have some tools, but it's not like a surgeon using a scalpel to remove something, but we try our best. And the third treatment option for Barrett's esophagus, which I'm going to go into more in detail today, is ablation. That's using energy and heat to destroy the cells of the esophagus. So I kind of have simplified it to like patients getting liquid nitrogen to moles and different lesions in their body. Cold is then destroying those cells. This is using heat. And so it's kind of like removing bad grass or sod and weeds from your lawn and then putting a new sod down to new cells to form. And when you have a very diseased yard, this is when you have a very diseased esophagus. So I briefly went over some of the pros and cons of each. When you're going to surveillance somebody, they have to come back for multiple endoscopies. And usually, at this point, before the advent of these therapies, prior to 2009 and 2008, surveillance was the only thing we had. I told patients, let me come back, let's see how aggressive is it, and if it does come, and unfortunately if it does become esophageal cancer, we'll have to talk about other treatment options. As patients with the dysplasia were even getting esophagectomies to prevent esophageal cancer, and that is a very difficult surgery. If you do get esophageal cancer, the prognosis is poor. The treatment options are not very good. 85% of people who get esophageal cancer die within the first year. And that's what's the most devastating thing about this disease. And that's what we're trying to prevent. The unfortunate thing about surveillance is you still worry. Is it going to become esophageal cancer? Well, I know the doctor told me it's going to be 1 in 200 people, but human nature is to worry, and we worry about that. So that's something to think about. And it is requiring us to do, frequent visits. But it is not a bad option if your doctor surveillance you on a regular interval and you're not too upset and not too worried about it. If you have no family history of esophageal cancer, you're controlling your acid reflux. It's something to consider for some people. Going to the PDT, the photodynamic therapy, once again, it's good. It does destroy the tissue, but the problem is if for 4 to 6 weeks you have to stay out of sunlight. Here in Florida, that's a problem. And you can have very severe burns on your face and arms and legs if you are exposed to sunlight. And you can definitely see some stricturing from that. You can have some scarring of the esophagus and some difficulty swallowing with photodynamic therapy. EMR, the good thing about it is it removes the tissue, and we know that we're taking it away. The problems are that it can, sometimes there can be some tissue underneath it that's not completely removed. Larger areas are quite difficult. It would be hard for me to remove the tissue of a whole circumferential lesion that's 360 degrees in the esophagus. And usually it still requires some heat or ablation therapy to destroy the other cells. So this is ablation, and Barracks Medical has developed the technology to destroy the lining of the esophagus and making a small burn where it does not burn completely through the whole lining of the esophagus, just burning the superficial layer that develops into esophageal cancer and trying to prevent it from happening. The good things about halo ablation is that it's fast, and they're about 24 minutes average in procedure. It is done as an outpatient setting. Patients go home that day. It does remove that thin layer of cells that we talked about without harming the muscle underneath that lining in the esophagus. It allows for normal growth, like taking out the sod of a lawn and putting new grass in or new seeds. And the stricturing is not as significant as the photodynamic therapy. The cons of it are, it can be quite painful. Some patients have had significant pain afterwards, but we medicate them with pain medication. And it's something where after you've had a bad burn to your esophagus, you can't eat. And so they're usually on a liquid diet. I usually put patients on it for a week after the ablation and then slowly increase it to a soft diet, because you wouldn't want to eat something very spicy like chips and salsa or something that has a lot of texture. You wouldn't want to put that on your esophagus after burning it. And I'll show you some pictures of that. Usually it takes about 3 ablations to totally eradicate all of the lining, the bad lining, and the new lining. I've seen some very good results after 1 or 2 ablations and not had to do any further treatment. And usually they come back in about 2 months and have it looked at and surveillance, and if necessary, touched up. And we'll talk about that. So this is, I talked about Halo 360. So that is a 360-degree circumferential treatment. For that first picture I showed you of Barrett's esophagus, it was around the entire esophagus. So to treat it, we initially, with our scope, place a balloon catheter that sizes the esophagus. Not everyone's esophagus is the same size. So we have to see, because we want the connection of the coils that burn to touch the lining of the esophagus. So if you have a large esophagus, we use a small balloon. It won't touch. There will be no contact. So when we do deploy the energy, there is actually no contact and no deterioration of that tissue. So we find out the size of the patient's esophagus. Then we use a certain catheter, there's different sizes. Then we pass, this is our endoscope, we pass the catheter down, and it's usually over a wire so we know we're in the stomach. And then we inflate the balloon. The balloon is inflated. With a pedal, I push down, and heat is then deployed, and it is actually burning the lining of the esophagus. And you see that these burn marks here in the esophagus. Okay, once again, I'm going to show you another picture here. This is the esophagus, and this is the Barrett's esophagus from here to here. This is normal lining of the esophagus. Here's the stomach. We then figure out the size of the balloon needed for the esophagus, come back with the coils, and then we inflate the coils, and we deploy the tissue. We deploy the current. There it is. And then it looks like this. Then we can extend it a little further and burn the bottom portion of it. So we can really destroy long segments of Barrett's esophagus. Barrett's esophagus is in 2 classifications: short segment Barrett's esophagus and long segment Barrett's esophagus. Short segment Barrett's esophagus is 3 centimeters or less. Long segment is 3 centimeters or greater. So be aware of that. And that was a long segment. This catheter and the coils are 3 centimeters. So this was a 6 centimeter segment of Barrett's esophagus, which we would call long segment Barrett's esophagus. Okay, there's the cells, that's a sloughing, and you'll see it. It's almost like, I try to describe to my patients, it's like when you drink a hot coffee or hot tea and you feel the lining on the top of your mouth slough off. That's exactly what this is, and you can see that lining, that coagulum of burnt tissue, and you can kind of almost feel it in the back of your mouth. That's exactly what is happening here to the esophagus. Okay, and this is after ablating a long segment. You can see here, this is that white coagulum, but they've scraped it off. So this is the underlying, good soil in the lawn analogy that I was using. This is the normal lining of the esophagus, and this is after burning this whole segment. These are using that balloon and the coils, and this is what it looks like. So if you have smaller areas and don't have the circumferential, you can use what's called the Halo 90. And it's a panel that is attached to the end of the endoscope and can be applied directly to specific areas. And you can see here that the panel is being added to the end of the scope, and then the panel then is directed and visualized burning specific tissue, and you can see that right there, a little square is. And I can use that panel to go all the way around, touch up areas. So it's very effective, and the maneuverability is a little bit better with it. The balloon, once again, is better for larger segments. Here you can see here, there's a small area right here, just an area of Barrett's. It's called an island of Barrett's. And then this is the panel that I was talking about. Those are the coils, and the coils are then applied and with a foot pedal, burning that area. Looks pretty good. And there's that area, this is the burning on the top of your mouth after coffee. That's what you're feeling, and it comes right off, and you can scrape it off. Once again, this is an actual patient, and you can see what the esophagus looks like after 2 years after doing the ablation. So this is a real patient. Pretty impressive. And I do see these results quite regularly. Once again, you see this. So this is the same patient. You see that that's a normal island right here. And look at the lining now. It's all normalized to normal squamous epithelium. Okay, so basically, the studies have all shown how effective is it. And if you can look here, it's a kind of a busy slide. Basically, if you have plain Barrett's esophagus, after 2.5 years, 98% of people no longer have any Barrett's esophagus. So that's taking the population studies of patients they've treated. If you have low-grade dysplasia, after 2.5 years, 90% are treated or eradicated from their Barrett's esophagus and low-grade dysplasia. If you have high-grade dysplasia, the results are approximately 90%. They're very good. These are better options than that surgeon doing that surgery to you where you saw earlier where the esophagus was being filleted open. There's Barrett's esophagus. It's probably, there's some television ads about it. And it is something that you should discuss with your doctor. But basically, Barrett's esophagus and esophageal cancer is a growing problem. And I think we all need to lose a little bit of weight, diet, and exercise to try to prevent acid reflux. And if your acid reflux is not controlled, you should be on medications. And your doctor can tell you which ones are best for you. But there are treatment options if you do develop a precancerous condition. And you should be aggressive in your life to try to address these so you don't develop esophageal cancer. And that's important, and that's what this talk is about today. So basically, the conclusion, talk to your physician if you're having heartburn. Discuss your family history with your physician. A lot of people don't do that. They say, well, you know, what did mother or father die of, or what do they have? And those are very, helpful clues to a doctor. Look for alarm symptoms. Now, the bad things that we get concerned about is acid reflux that's uncontrolled by medication. Difficulty swallowing. Difficulty swallowing is a problem. It means that there's either something obstructing it or the esophagus is not working well. And that can be a sign of early esophageal cancer. Coughing that's uncontrolled, nausea, vomiting, and unexpected weight loss. By the time you're starting having weight loss and no symptoms, most likely that is a sign of some serious malignancy and sometimes even metastases in the body. So if you're starting to lose weight and you're having a normal diet, talk to your doctor, please. Avoid large meals and overeating. Take your medications as prescribed, and please enjoy life. Okay? So this is the end of the talk. Good. We have a microphone around the audience, so if anyone has questions, feel free. She's going to.
You've talked about overeating. Are there any specifics that you should not eat or drink?
Very good.
There's no mention of alcohol.
Yeah. So alcohol can cause acid reflux and can accelerate acid reflux. Certain foods do lower the esophagus's sphincter. Peppermint, chocolate, citrus foods can accelerate acid reflux and cause acid reflux. I have personally issues with bell peppers and onions. So each person is different, and there are some foods, and if those foods do trigger symptoms, you should avoid them. Okay? Very good. Okay, sorry. Yes, ma'am. Yes, sir.
I like spicy foods, Tabasco sauce,
Correct.
and jalapeno peppers, etc. Are they bad for me?
Actually, going back to my last thing, enjoy life. If those make you happy and they make your meal more pleasurable, I would definitely do it in moderation. And moderation is the key. If it does cause you significant acid reflux or heartburn, then I would probably avoid it. So it's all dependent. Some people can eat those types of foods without having any symptoms, and I would say continue. So nothing's been proven that Tabasco sauce, chilies, red pepper, salsa causes esophageal cancer or acid reflux or Barrett's esophagus. Okay? Yes.
Hi, 2 questions. What is the long-term surveillance post-ablation? After the ablation is done, what's the follow-up?
Very good. So usually after you've ablated, and this is all variable and each doctor is different, but what I would recommend after you've had ablation, you should come back after 1 year. In 1 year, we should take a look and see what is the esophagus look like. And if that point needs a little touch-up, can be done. If it looks good, like that other picture you saw, I would then push it to 3 years. And I would think safely every 3 to 5 years after that would be fine, because it still takes time, for you if you were to develop esophageal cancer. Barrett's esophagus and esophageal cancer. So once you see that there's no pre-malignant tissue in the lining of the esophagus, you can then rest assured, and 3 to 5 years is fine.
So given that, my second question was, does there have to be complete ablation And if there's not, then it sounds like you'd have to have that same routine follow-up.
Correct. And so if you're going to start this, your whole goal is to treat and to eradicate the tissue. Okay? Yes, sir.
Doctor, first of all, thank you very much for your presentation. It's very concise and easy to understand. My question is, what type of a timeline is there from the onset of someone saying, hey, I'm really getting a lot of heartburn, until you have a problem? Okay.
Okay, very
With
good.
Barrett's.
So initially, if you have a problem, the timeline, is probably somewhere in the 20 to 30 year range, probably. It's not an overnight thing. It's not a weekly thing. It probably does take some time, but it's accelerated in patients who smoke, in obesity. It's more prevalent in white males after the age of 50. So that's where, so if you're a 20 or 30-year-old having acid reflux and heartburn, you definitely can have problems such as esophagitis, significant erosions in the lining of the esophagus, difficulty swallowing. But most likely you're not going to have Barrett's esophagus. I've seen Barrett's esophagus in some patients in their 30s, but most likely they're over the age, in their 50s, 60s, 70s, and beyond. So it is not something that you should be worried about just for 1 or 2 episodes of acid reflux. Yes.
Hi, Dr. Gopal.
Hi, how are
It's
you?
good to see you
Good to
again.
see you.
My husband died of esophageal cancer at the age of 50, and the symptoms that you described, the weight loss, that was one of the first things that I had seen in my husband, and I kept encouraging him to go get treatment, and the only thing they gave him was what I call Band-Aid treatment, which was antacids, which did nothing. He had GERD for well over 14 years, and it got to the point where he was vomiting. He had to sleep propped up.
Right.
Some of the things that I wondered about, are there tumor markers like CEA that can be utilized, and is there a difference between hyperplasia and metaplasia?
So I'm sorry to hear that. So this hits at home when I'm talking about esophageal cancer, because you've lived it and you've experienced it, and it is unfortunate, and sometimes it's too late when you start having those symptoms. In regards to the blood testing, there isn't anything now to prevent it. Usually the CEA level is a marker when you already have advanced disease or have disease in your body, and it can be used as a tool after you've had a major surgery or resection of that cancer or chemotherapy to see, is it coming back. So it is a test. It's not the greatest test, but it's not a good screening test. If the CEA level is already positive when you have acid reflux or have Barrett's esophagus, that's a bad sign. We want to try to prevent that CEA level, which is a blood test, from ever rising. So intestinal metaplasia is Barrett's esophagus. Intestinal hyperplasia is not as aggressive. It is not a malignant condition. People don't know the long-term transition of hyperplasia. We see that a lot in biopsies, but it's not something that has been proven to develop esophageal cancer.
And one other thing, I have low gastrin levels, and I take a number of medicines. Do medicines, and I'm not talking about antacids, do they contribute to esophageal cancer, and especially with the low gastrin levels?
So gastrin levels I do not know, but other medications, I think if you've had previous malignancy or cancer and chemotherapy, your risk is increased, because the body's own defense system is not as strong to address it. But specifically, no medication has been linked to esophageal cancer, I think, but that's something to think about, and so far the links have not been made.
Thank you.
Thank you.
And I encourage everybody, please get tested. If you have symptoms, don't ignore it. Our bodies are our temples, and we take care of our vehicles because we rely on them. We have to rely on ourselves to maintain our bodies.
Right.
And I am one of Dr. Gopal's patients for other things, and I can tell you, he's very caring, he's very knowledgeable. Please go to him or another doctor and get tested. My husband wanted to be remembered, and I hope you all will remember him and get yourself tested.
Thank you, doctor, for taking my question. I've recently been diagnosed with gastroparesis. Is this a form of the Barrett's, or does it have anything to do with it? Is it connected in any way?
Well, so gastroparesis is slow emptying of the stomach. It's when the stomach does not function well, when the stomach dilates instead of compressing and pumping food into your small intestine. So when you do have gastroparesis, slow emptying of the stomach, you can have acid reflux, you can have nausea, you can have GERD symptoms. So patients who have gastroparesis are symptomatic with acid reflux, and you talk to the doctor about treatment options for gastroparesis. But the gastroparesis is not shown to increase your risk of Barrett's esophagus or esophageal cancer, but you can have acid reflux-like symptoms.
Thank you.
Thank you. How about right here? Go. Oh, micro. I'm sorry. I'll go with the. You want to stand? Good. If you want to tell me the question, I'll repeat it, and then we'll go back.
I've been hearing a lot of really negative stuff about proton pump inhibitors, and that when you stop them, you have worse symptoms than if you never went on them. And so, are you doomed once you start them to take them for the rest of your life? What should we do about
proton pump inhibitors? So,
before we ever get on them?
Correct. So proton pump inhibitors are acid suppression medications like Prilosec, Nexium, Protonix. So those are medications that have been out for quite some time. Prilosec's been out for 30 years now. And that's the problem. We live in America. We have an Americanized diet. We like to eat spicier foods, larger foods, as people said. And so that's part of our culture. I think if we lived on the farm and ate off of the land, we probably would not have these issues with acid reflux and heartburn that we do experience. We overindulge in alcohol, sweets, and that's the problem. That's our diet. So we try to prevent it dietary before having acid reflux. Your second point about long-term use of PPIs, in certain studies in the elderly population, and especially the nursing home population, there's been an increased risk of hip fractures and pneumonia because the acid's not being produced to kill the bacteria in the mouth, and that bacteria then is going into the lungs and causing pneumonia. But if you have a good cough reflex, if you've not had a stroke and symptoms like that, it's fine. But the bottom line is it's quality of life. If your quality of life is being affected by acid reflux and heartburn, then you should take something because it can be very debilitating to not feel well after a meal. So it's kind of a lifestyle thing, and it's also quality of life.
Okay. I take Nexium, and I have acid reflux, and I got to sleep straight up. I can't lay down real low.
So I would recommend, hopefully you take that medication in the morning. You may need to take it twice a day, so you should talk to your doctor about that, about maybe you need more than once a day therapy. And then you should work on things like elevating the head of the bed, even putting some blocks under the head of the bed, not just doing your neck, your whole thorax up so that you're not having acid reflux. Some people sleep in recliners, unfortunately. There are some surgical options for acid reflux, and you could talk to your doctor about that. But overall, this is very common.
Okay, thank you.
Thank you.
I want to ask you about the Barrett's esophagus. I know that isn't that a flap between the stomach and the esophagus that's supposed to keep the acids from coming up? What happens that it doesn't do what it's supposed to do?
Very good. So there's not actually a flap. It's called a sphincter.
Okay.
So it's a
opening?
A circular muscle.
Okay.
Just like the anus that closes and opens and closes. And certain actually foods relax that sphincter. As I said, peppermints, chocolate, alcohol, cigarettes, all of those things reduce the sphincter. Because of gaining weight and increasing your abdominal pressure and belly fat, even wearing tight-fitting clothing, all compress and put pressure on the stomach. So the stomach is a bag. When you put pressure on it, guess what? It then causes increase in reflux, and that's what happens there. There's no flap. Lose weight and don't wear tight-fitting clothing. Isn't it? Thank you.
I was once prescribed medicine for GERD years ago when I had a chronic sore throat that nothing would help. And then, that kind of went away with just some over-the-counter something.
Good.
And then for the last year, I've had hoarseness and kind of chronic clearing of the throat. And the only thing they've come up with is GERD. Is that a symptom? I mean, it's not a symptom I heard you mention.
No. So some of the ENT, ear, nose, and throat doctors are thinking that it's non-acid reflux. Sometimes it's liquid and fluid, that we normally produce in the stomach that could be causing laryngeal reflux and causing hoarseness and voice changes. So those things you work on, you could have postnasal drip, you could have allergies, and those are things to be addressed. Having hoarseness is a sign of GERD, but it's not a sign of esophageal cancer. But it can be addressed.
But it can be a sign, because the only thing that seems to help is like Prilosec twice a day.
Yeah, so it's okay, take it.
It's okay?
Yeah.
Okay. Thanks.
Thank you. So good. We have a lot of questions up front too also.
Okay.
Thank you.
Good morning or good afternoon. Good afternoon, everyone. My name is Barbara. And right now I'm thinking that you use the term GERD and acid reflux interchangeably.
Yes.
That's interchangeable. Yes. Number two,
and
I take
Heartburn.
Oprimazole.
Yeah.
Oprimazole.
Yep.
For GERD.
Good.
And I'm wondering, is this sign anybody else has right here? Is that a sign of GERD or I'm serious. I can do that.
Okay.
24 hours a day, I can belch for you.
Right? So basically what you are swallowing or consuming some air. So you don't believe it or not, but you're actually consuming air. It's in your stomach, and you're actually releasing it. So that's basically, so you're having aerophagia. So either you may not realize it, but you may be swallowing a significant amount of air when you talk, when you chew, when you eat. And so then you can actually expel that air, which is a burp or belch, which you're doing right there. But so don't do that.
Okay, my question is Barrett's and GERD's the same thing?
No. So GERD is acid reflux or heartburn, and years of GERD can lead to changes in the lining.
Okay, and do I understand this correctly? There's 3 different levels of Barrett's esophagus: low-grade dysplasia, high-grade intensive.
So very good. So there's plain vanilla Barrett's, and that's with no dysplasia. Then there's low-grade dysplasia, high-grade dysplasia, and then unfortunately that leads to esophageal cancer.
And at what point is treatment required when you're diagnosed or recommended when you're diagnosed with Barrett's esophagus?
Very good.
And can medication be used?
So no studies have ever shown that PPIs or omeprazole or Nexium have prevented esophageal cancer. But if you're still having exposure to acid to this tissue, that can sometimes, hopefully in theory, is that the insult, by decreasing it, should hopefully decrease the progression of disease. So if you had regular Barrett's esophagus, you should talk to your doctor about it, but usually that doesn't mean that you necessarily need treatment. But if you start seeing, if biopsies do show low-grade dysplasia or high-grade dysplasia, then you should treat it if you're healthy otherwise and have no other medical issues, because long-term it can be a problem.
Is there Barrett's esophagus with dysplasia and without dysplasia?
There is. So dysplasia is bad. That means that it's getting more aggressive. So, but you can develop esophageal cancer just from Barrett's, but it's not as likely. And then the dysplasia then accelerates that change to cancer. So it's like going from warm to hot to on fire.
I want to thank you so much for being here. You've answered so many of my questions. I've had this for about 30 years, since when Prilosec was just starting.
Right. It's been out for 30 years.
And it has now gotten a lot worse, and I'm very, very interested in this ablation thing. What is the next step? What do you do if you are interested in this? Because I've had a colonoscopy and an endoscopy just in January, but I've got this. I've got a lot of symptoms. coughing, the vomiting, and I'm getting concerned. So I wanted to know what to do next.
The good thing is you had an endoscopy, so that would have identified if you have Barrett's esophagus. So you do have it. So then what you should do is when you sit down and talk to your doctor, you look at your age, you look at your risk factors, you look at your other comorbidities. You know, if you're a healthy person otherwise, or do you have other issues, if you've had other cancers, if you've had heart disease, if you have lung disease, and then can decide whether or not you should be ablated or not. So if you do have Barrett's esophagus, and that was recently found in January, most likely you should have another endoscopy with biopsies again in 3 to 6 months to see truly is it there, and then is it any dysplasia.
How do I get to you?
I'm in the phone book. But please call my office. Yes. Go ahead.
You have mentioned about coughing.
Mm-hmm.
How is that related to Barrett's esophagus?
So coughing is not related to Barrett's esophagus. Coughing can be a sign of acid reflux. Acid coming in the back of the mouth, a brackish or bad taste, and that irritation of acid can affect the vocal cords, causing coughing.
Go ahead. We want to thank Dr. Gopal for coming today. A very thorough and informative presentation, but I see you have one more question.
One question, and then we'll end it. Thank you.
I guess that's me.
Yes, ma'am.
But I raised my hand first.
Okay, good.
I can close this thing out, I think. First of all, I'd like to thank you for the presentation, and I'd like to have a copy of your presentation, or is it on a website that we can go and look at it?
Yes, it will be on WJXT.org.
JCT?
Oh,
but that's okay.
Sorry.
WJCT.org, and then go to podcasts.
Okay.
And I think it's up for a couple of weeks.
I know I have a problem, but I can't take capsules. What kind of a liquid medication do you recommend?
So there are formulations of liquid acid suppression medication, and those can be given to you. There's even some under-the-tongue medications or dissolvable medications that you can take. Nexium makes a liquid version, and a lot of the other medications, Acifex has a dissolvable tablet.
And the next question is, since I've been having it for so much, how do you go in there and find out that I might have a real infection? Or
by doing an endoscopy for the doctor to pass a
but
scope.
The drinking of all that white stuff, you can't see it?
Very good. No, so that is a very crude test, and it was one of the better tests that we had a while back. It's where it basically just takes the rough outline of the esophagus. So you drink that white chalky stuff, and then you have x-rays to look at your esophagus. So it really doesn't look at the lining. It doesn't look at the texture of it. It can tell you if it's straight. It can tell you if there's a big obstruction or blockage in the plumbing, but it doesn't tell you much. Endoscopy, you can take a biopsy, you can take a look, you can actually take pictures of it.
I'll have my physician do just that.
Okay,
Thank
good.
you.
Thank you. Thank you, guys.
Thank you very much.
Thank you. Is it mic off? Good job.